of catching up. You know, we've covered the single most humongous topic of all, which is GI pathology. And we went all throughout the GI system. We did a lot of stuff on the liver. We did a lot of stuff on the pancreas. And we started to diddle around with histopathology lab last week, and we got a lot of technical problems. And I hope we fixed them by now, because today, boys and girls, we are going to do nothing but histopathology lab today, just like we did on the island. Okay, only now, rather than half the students be online and half the students be in the room, everybody's going to be online. So I really whipped up like a whole bunch of cases for today, and they're not every single GI case from the workbook, but there's a lot of them. There's probably about, 20 or 30 or so, and if we have the time, we'll do them all. And if we can do them all before the time is over, then we'll get out early. But there's a good number of cases on here. And I think that we really have to do some catching up. Let me say two things about the backup concept and the algorithm concept. The backup concept means the more experience you get in microscopy, the more you do not have to zoom in under high power. And there's far-reaching applications of that principle. A lot of young pathology residents and students and inexperienced microscopists, they will go to that slide and zoom, 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 zoom. And before you know it, they can't really see the forest for the trees because they're zooming in on some stupid nucleolus and they're failing to see the big picture. And the fact is, most diseases are not even at the cellular level, but they're at the supracellular level. So you have to back up, perhaps to the point of not even being able to see nuclei and look at overall patterns. And that's what we're going to be doing today. And part of the backup principle leads into the concept of visual algorithms. So as you know, we have been spending a lot of time talking about diseases of the alimentary tract, in other words, esophagus, stomach, intestines, appendix. And we talked about over and over again the basic histologic organizations of the four classical layers of all of these GI areas. In other words, mucosa, submucosa, muscularis, and then that little piece of connective tissue on the outside, which we called either adventitia or serosa, depending on whether it was intraperitoneal or retroperitoneal or not. So what we're going to do is take a look at, once again, review some quick normal patterns. I'm going to tell you the actual algorithms to write down on a piece of paper because they're going to be very, very brief for each organ and each tissue. And then we're going to do the same thing for liver, and we're going to do the same thing for pancreas. And they're going to be extremely small, brief, visual guidelines to keep in mind whenever you examine that piece of tissue. They're so incredibly simple, they're almost not worth writing down. But they're so incredibly important, you have to write them down. So I am assuming, because everybody is quiet and I don't see anybody complaining about anything, including me, that we are basically communicating right now. And you know what the drill is. I'm going to be whipping out some slides, and I'm going to be, I don't know, maybe I'll be talking to myself, and maybe I'll be talking to people. But it looks like everything is good because Jim said so. And if Antoinette says so, then we know everything is going good. So let's go to the GI tract. We're going to have nothing but lab today. None of those stupid PowerPoint bullets. We're going to strictly hang out in the lab, have a cup of coffee, do some good rock and roll hanging around, and then we're going to go home. Because I started the list here under the topic of the gastrointestinal system, the slides were arranged alphabetically. So it's not surprising that the very first case is going to be something called appendix because appendix begins with A. So I went into the list and I did a little bit of preparation and I looked up the classical normal appendix again, and it tells me that that is case number 4001. Uh-oh, what happened to 4001? Oh, don't tell me I screwed up. Hold on, let's look at it a different way. Maybe we got another way of looking at the appendix. Where's my appendix here? Well, guess what, folks? My normal appendix is not here unless I look over here. Hold on for 1 second. I'm going to find this damn thing because you can't really start to show a bunch of abnormals unless you look at the normals. So I'm going to find the number for the normal appendix. And we're going to do this the right way. Oh my God, we don't have it. I can't believe we don't have it. That's the only one I didn't check. Let's look at one more time. I thought we had it. Well, we don't have it. So guess what? We're not going to do normal appendix. What we're going to do is move down to the next letter of alphabet, and it would be the next alphabetical case in your slide box, which is AACR 5928. And I'm not going to tell you what it is because you should be able to recognize most of these. AACR, oh my God, and don't you dare tell me we can't find that one either. Whoa, what's happening with me? I can't believe I didn't check this out better. Here, let's do this one. 4663. Okay, we got some good stuff now. Okay, I'm going to ask anybody to tell me as soon as they see the tissue under the microscope. You see it, Margaret? Hello?
I was muted. No, we just see dim room. I don't know what happened.
Does anybody see the tissue under the microscope?
No. See the dim thing.
You know what? We got the same problem that we had the other day, don't we? You know, this is very, very upsetting because if you remember, we had about 20 classes where we were able to see the slides easily. And I don't know what happened. You know, we're connected very well on DimDim. We are on the full screen mode. So, you know, you should be able to see this. And yes. Well, DimDim is, okay, hold on for a second. I think you should be able to see it now or very soon. If not, we'll go back in. Okay. Well, what do I press on, Jim? I see my DimDim is going. How do I get it back going without rebooting everything? Okay, I'll do that. Okay, you should be able to see the slide very soon. We're back in business over here. Okay, I'll give you the URL again if for some reason you were kicked out. But you should be seeing a slide here very soon. Okay. I am not happy today.
I see it's kind of like a double picture, and it's gray, but you can see it's transparent that you can see through it.
Are you seeing the slide?
I don't see a slide. No.
You're seeing the slide very soon.
Someone said yes.
It is there.
Dolores
Okay, it
sees
looks like,
it.
is there anybody who can't see the slide?
I see it now.
What does no mean, Jessica? Does that mean no, you can't see the slide or? Okay, a lot of people still can't see it. And I'm not happy because this has never happened before. Jessica can see it now. Satya can see it now. Everybody can see the slide now. Okay. Um, let's see if Lois can see it now. Okay, good. You're seeing a slide, and I think what you could see, at least from this power, is that it's a GI tract organ. And you could see a band of smooth muscle on the top. And you could see that there's a lot of loose submucosal, soft, loose, vascular, connective tissue between the muscularis and the mucosa. And you can see the mucosa, and it's in a wavy sort of pattern. And so just from the fact that you see something like this, you know it can't be esophagus, and it can't be small bowel either, because there is not a villus pattern. And the person who just said large bowel is correct. This is a classical colon. You could possibly get it confused with the pyloric portion of a stomach, theoretically speaking, but it's a classical large bowel. So you have your mucosa, you have your loose submucosa, you have vessels in the submucosa, you have a lot of smooth muscle, and it's not thick enough. The slide is not big enough to actually see the serosa or adventitia, depending on what part of the colon it is. But look, the one thing that you could see from this backup view is that there seem to be a lot of these little focal collections of lymphocytes in the mucosa and in the submucosa, the so-called Peyer's patches or lymphoid follicles or primary and secondary follicles. And if they were simply just patches of lymphocytes, you could call them a primary follicle. And if you thought you saw a germinal center, you could call them a secondary follicle. So at this point, I think you're thinking, if there's any disease here at all, the muscle looks great, the submucosa looks great. So let's look at the mucosa and see what we want to say. Well, the first thing you see is that there is some ulceration of this mucosa. You can see there's areas here where you have loss of surface epithelium. In fact, there's bigger areas of loss of surface epithelium. And in addition, these infiltrates of inflammatory cells, which look primarily like chronic inflammatory cells, seem to be a little bit more than usual. And in addition, it even looks like there's a collection of inflammatory cells within this crypt of Lieberkühn. And that's what they call a crypt abscess. And what I'm going to do is blow this up now even more. I remember the lag time. It's going to take about 10 seconds. I think everybody sees it. I'm not going too fast. Okay, Tell me when you can see the blow-up view, Jim. That should be in a few seconds. Okay, got it. Is there anybody who can't see the blow-up view of the colon yet, where you could see a lot of glands? So what you're seeing here towards the bottom is a mucosa. What you're seeing between the glands of the mucosa is the lamina propria. And I think I could convince you that there are a lot of extra inflammatory cells in this lamina propria. And I think I can also convince you that there's some mostly chronic inflammatory cells in the superficial portions of the submucosa as well. But the thing I want you to notice the most is right here directly on the bottom, where Texas is that you see a collection of inflammatory cells within the crypt. Well, what do you call a localized collection of acute inflammatory cells? You call it an abscess, don't you? So this is what they call a crypt abscess, or collection of neutrophils within the crypt. And crypt abscesses are very, very, very characteristic of inflammatory bowel disease. And they're very, very, very characteristic of ulcerative colitis rather than Crohn's colitis. You can see another one here where my pointer is, I think, and you can see a bigger one here in which you see not only an abscess, but you could see it's also causing attenuation of the epithelial cells of the crypt as well. And in addition, you just see more inflammatory cells throughout the mucosa and superficial submucosa as well. Okay, now I'm going to go back to the big picture again. And probably in about 8 seconds, hopefully everybody will see the full slide again. Because remember, pathology is a disease of backing up. So we have a mucosa here once again, and we can see a submucosa, which is largely spared of inflammatory changes, except for perhaps the very superficial portions. And we see a muscularis or muscularis propria, which looks normal too, even though we don't see the entire thing. So this is what we call the moment of truth. Let's really think about what we just saw. What we saw is a slide of a colon in which there appear to be inflammatory changes within the mucosa, but they're limited to the mucosa primarily, and there's ulceration, and we saw a crypt abscess. Well, we know it's not cancer because we don't see any glandular proliferations. So, ladies and gentlemen, I want to tell you exactly what we're looking at because I know you're on your toes right now in with bated anticipation. This is the most classical case of chronic ulcerative colitis you'll ever see. In other words, it is one of the main types of primary inflammatory bowel disease. Remember, we spent a lot of time on it. This is ulcerative colitis. Now, whenever you see primary inflammatory bowel disease, you have to differentiate whether it's Crohn's colitis or ulcerative colitis. We said that with Crohn's colitis, if you look well enough, you'll probably find granulomas because another name for Crohn's colitis is granulomatous colitis. We didn't see any granulomas, but we saw ulceration and we saw crypt abscesses. So the point to take home here, and I hope you're all listening, is that when you see a crypt abscess with no granulomas and the inflammation is limited to the mucosa, this is not Crohn's colitis, this is ulcerative colitis. So we're done with this case. But remember what the three histologic features of ulcerative colitis is that's limited to the mucosa. It has crypt abscesses. And it's not a full thickness colitis like Crohn's colitis is. Just out of curiosity, did everybody hear me talk about that slide just now? I'm assuming everybody heard me and can see what I'm looking at by now also. Okay, good. That's one case. It looks like everybody got it. I'm not going to embarrass anybody by making them get up in front of the screen. Uh, so let's move on to the next case. These are all classical cases, by the way. There are a few cases that are in the slide collection that are relatively rare and exotic, but I only chose the ones that are like classical, basic histopathologic uh, appearances. I'm going to go now to the next one called 4379. And if that one's missing, then I'll really bang my head against the wall. 4379. Okay. Oh, this is a good case. This is a good case. I'm sure you all see it in a few seconds too. Okay, Dolores can see it already. I guess we're getting faster now. So as long as you're there, let me ask you a quick question again. What's the organ? Well, you know it's not a liver. You know it's not an esophagus because it doesn't have squamous mucosa. You know that there's a mucosa over here. There's a submucosa, this loose vascular connective tissue here. And then we have a muscularis here. So this is probably either small bowel or large bowel. And because the arrangement of the mucosa is not papillary or villous, like villi, it's relatively flat with pits and crypts. This is, again, large bowel. This is a colon. And right now, I want to tell you the algorithm for all gastrointestinal organs. In an orderly fashion, you have to look at the mucosa and you ask yourself, is it squamous or is it glandular? Well, if it's squamous, it's esophagus, isn't it? If it's glandular, it's either small bowel, large bowel, or stomach. If it's glandular with precise villus projections, then it's small bowel, isn't it? If it's glandular with pits and crypts, then it's either stomach or large bowel. But stomach, as you remember, has three muscle layers. Remember, there's an oblique, there's a circular, and then there's a longitudinal. Here, you only see two. You see a circular on the inside, which you see down here, and you see a little thin longitudinal on the outside. And remember, if you were in an area of a taenia, the smooth muscle would be a lot bigger because taenias are the big, thick, longitudinal muscle layers. So once again, this is colon. So you've identified the mucosa, then you look at the submucosa and you say, is it uniform and loose? And does every part of the submucosa more or less look like every other part? And then you go down and you look at the muscularis. And you say, well, is it of relatively uniform thickness? Does it have inflammatory cells between the fibers? Can I see little separation sometimes between the circular and longitudinal or oblique layers or whatever it is? And then you look at the outside, the loose connective tissue. And if you think you see some mesothelial cells surrounding the outermost layer, then you say, well, yeah, this is probably something that is intraperitoneal, like small bowel or half of the large bowel, rather than retroperitoneal, in which you would only see connective tissue and no mesothelial cells. Folks, that is the algorithm. So having said that, let's take a look at this. And I wish I could show you more of it because this is a pretty simple, straightforward case. So I'm going to blow it up. And in about, maybe 5 or 6 seconds, I'm waiting for a couple people to say, I see it or something like that.
See it.
Okay, good. Pretty much you're all getting it at the same time. Here's your mucosa. Here's your submucosa. Here's your circular layer. Here's your longitudinal layer. You could probably see a Auerbach's, a ganglion collection here and here, so you know that that's part of the bowel's intrinsic brain system. And then you see some connective tissue of the serosa or adventitia. So in all honesty, this might sound like a kind of a stupid question, but in all honesty, there's only one thing in this whole slide that looks a little bit funny. And what looks a little bit funny is you have areas here in the submucosa that look like they have an overabundance of these large red blood vessels. Almost like there's a little hemangioma of the submucosa. Well, that might be a relatively good diagnosis because it's an honest diagnosis. But if you remember when we were talking about colon, I told you that there is a very, very common vascular disease of the large bowel, which is called angiodysplasia. And the word dysplasia does not imply pre-malignancy, but the word dysplasia just implies an overgrowth of large vessels. And because the blood vessels in any GI organ are the largest and most abundant in the submucosa, this is angiodysplasia of the colon. And Samer, just from the fact that you said large red, you know, I think that that was a very, very good observation because the key diagnostic features of this particular colon slide is that you have an overabundance of large red things, which are blood vessels, which are overgrowth of blood vessels, which means this is angiodysplasia. Okay, did everybody get that one? If you did,
Yes.
we'll move on. Okay. And by the way, you know, a lot of the pictures that I take and I show you in class, they are actually taken from these slides. I do not rely on ripping off or Googling a slide from, you know, the University of Utah medical collection. I make my own because they're much better when you take them off of the slide. Okay, let's do another case. And the next case we do will be 4044. And I think that's coming up. And here it is. It better be here. Oh, I know you're going to get this one. I just know you're going to get it. And in a few seconds, everybody will see it. Okay. Boys and girls, I think once again you could see that this is a colon. Why? Because you have a glandular mucosa down here in the southeast, and it is not arranged in a villus or fashion, you know, like the villi of the small intestine. So once again, you know that you are in a large intestine. You can see a lot of nice vessels here in the submucosa. And you could even see part of the smooth muscle up here in Oregon, where Jim is, because you could see these little bundles of smooth muscle. But as you might guess, it's not the submucosa or the smooth muscle that we want to show you on this case. It is actually the mucosa, because what you have here is normal mucosa, normal mucosa, normal mucosa. I'm traveling north, you know, in California, and now I'm coming up and normal mucosa. And then look, all of a sudden, this mucosa shows tremendous growth, doesn't it? It's like thickened to maybe 10 or 20 times as much as it should be. And in addition to that, I'm assuming you're all in focus now. There's something else I want to show you about this, because I'm going to blow this up one more power. So in addition to that, not only do we see a proliferation of the mucosa, but we could see that the pattern of proliferation is papillary, isn't it? It's villous. It's growing like little villi or little hairs. remember we said that villi are papillae. They are little nests of fibrovascular fibrous tissue surrounded by epithelial cells. So this is a proliferation of the colonic mucosa in which the glands are growing like grass rather than like little tubules. So ladies and gentlemen, does anybody want to take a real kind of a guess as to what this is? I mean, I'll accept all stupid answers and theories, even my own. But remember, I've already used the word villus on here, and I said it was a proliferation of the mucosa, didn't I? So what is this? Come on, anybody speak up. And I'll give you an A for today. Carolyn is going to make, well, in a way, you know what? That is not a bad guess because villus adenomas have an extremely high correlation with adenocarcinoma. So if you wanted to call it cancer, that wouldn't be terribly wrong because this is a villus adenoma. And I told you that whenever you see a villus adenoma, it has an extremely high correlation with the development of cancer, whereas the tubular adenomas, or what we call the adenomatous polyps, they have a statistical association, but it's not very high. And the fact is most of them do not develop into adenocarcinomas. So here, let me ask you one last question, and anybody is allowed to answer it, even if it's wrong. If you did not take out this villus adenoma, and remember, I'm calling it an adenoma, so by definition, I'm implying it's benign. But if I did not take out this villus mucosal proliferating adenoma, and I just left it in there for another year, another 5 years, another 10 years, another 20 years, what percentage of villus adenomas will eventually develop into adenocarcinomas? Give me a number from 0 to 100. Jessica says 30. That's pretty damn high. Samir doesn't think they develop into cancer at all. Carolyn says 10. Come on, Rick. I know you could get the answer. Because I mentioned this in class, by the way, and you're going to be surprised. Jessica is the highest guesser right now with 30. Do you want to know the correct answer? 100. So Margaret was the closest. Yeah, maybe it's not 100, maybe it's 90 or 95 or something. But really, all of the literature supports the fact that villus adenomas all eventually develop into adenocarcinomas. Whereas I don't know what the percentage is of tubular adenomas that develop into cancers, but it's a hell of a lot less than 100. It's probably less than 20. I don't know because time is the big feature here, but this is a villus adenoma. And remember, I'm not going to blow this up one more time. I want you to look at these long, slender, fibrovascular cores surrounded by columnar epithelial cells. Those are the villi. That's why it's called a villus adenoma, because the growth is arranged like a finger, like a papillary projection, rather than a tubular structure. That's a villus growth patterns. So if you were to theorize that a villus growth pattern of a mucosal adenoma is a lot more associated with cancer than a tubular growth pattern, you would be damn right. So we'll move on to the next case. Did everybody hear me and see pretty well on this case? I'm still kind of curious because of our original problems. So I'm hearing yes, 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 yes. Okay, let's go to the next case. This is another drop dead easy one, folks. 4770. Here it is. And you'll probably all see it in a few seconds. And I know you're going to get this one, even if I have to torture you into getting it. Okay, you'll be seeing a change pretty soon. In about 5 seconds, I think everybody will see a nice slide up here. So who's the first person that's going to see the slide? Let me know.
See it.
Okay, Q is the first one, and then I saw Margaret, and now we're seeing Jim. I want to see. Let's see who the last one is going to be. I'm not concerned with the first one. I'm concerned with the last one. Jim still doesn't see it. Dolores doesn't see it. Satya, what do you have to say? Satya says Isla doesn't see it. Dolores sees it now. Jim sees it now. Okay, everybody sees it. Good. That's really nice because I don't think I'm going to have to blow this thing up very much. I think you will all agree again that this is a gastrointestinal organ. I think you could tell that the stuff here, uh, superficial to the mucosa in the lumen, goes by the medical term caca. And then you could see the actual mucosa, and it's not a papillary type of mucosa like the villi of the small intestine. So once again, you know it's a large intestine. And you can see that here's the mucosa. Here's a little Peyer's patch down here. And then you can see a little bit of submucosa here. You can see a little submucosal projection, which is, if you remember in the colon, they're called haustrae. Just like in the small bowel, they're called plicae. Just like in the stomach, they're called rugae. And that's basic anatomy, folks. You don't have to know pathology to know that. And then you have your muscular layer. So let me ask you this. Let's say that you were looking at this nice, relatively classical normal colon here, but then you saw that the lumen is actually bulging out into the fat. Oh yeah, you could still see a little bit of mucosa, but you hardly see any muscularis at all. And you can see some submucosa, and then you see some connective tissue. Anybody want to guess what the hell this is? Or do you want me to talk you into it some more? Yeah, Margaret, very good. I would probably, and Rick, yeah, you're pretty damn smart too. But you know what? I would probably not call it diverticulitis. I would probably call it diverticulosis. Now, if you see a couple of inflammatory cells here and you say, Dr. Minarsik, I want to call this diverticulitis because it looks like this big diverticulum is inflamed, I would say, okay, well, you call it diverticulitis. But for the most part, it's not inflamed, is it? Now, here's my next question. Let's say that this is the real lumen of the colon down here in Florida, but then the whole Pacific Northwest is the lumen of the diverticulum. Well, remember, we said that the classical layers of a wall is mucosa, submucosa, muscularis, and then serosa or adventitia. Well, how many of those 4 layers are in the diverticulum? You see some mucosa, you see some submucosa, you don't see much muscularis at all, maybe tiny bit. And then you see some pericolonic connective tissue, which you might want to call adventitia or serosa. So here's my next question. Is this diverticulum a full 4-layered wall or not? I know you're thinking. Actually, I'm thinking too, because you do see a little bit of muscle and you see some mucosa and submucosa. So if you said, yeah, technically it's a true diverticulum because it has all 4 layers, then I wouldn't fight with you. But if you remember, I told you most diverticulae of the colon don't have much smooth muscle around them. It's basically just mucosa and submucosa and connective tissue. So if you wanted to call it a pseudo diverticulum rather than a true diverticulum, because it does not have all 4 layers, then you would be thinking absolutely correctly. By the way, does everybody see the big diverticulum, and does everybody hear me? Okay, thank you. I love it when everybody responds quickly. Then I don't feel alone, and I feel I have somebody here besides Sandy. Okay, let's go to the next case. And I hope you get to see it pretty quickly. UNS, let's see if we could, if this one is here or not. No, let's go to this one. 4043. Okay, probably in about 8 seconds, you're going to be seeing something here. And I just saw it myself right now. So I'm assuming that you're going to be seeing it in about 10 seconds. And don't tell me Jim sees it already. Oh my God, everybody sees it quick. I'm feeling really good now. Okay, once again, let's go back to our basic algorithms. You ask yourself, before you just get into your little diagnostic mode, you better go back to your airplane and check the basic checklist before you do your fancy flight maneuvers. And your basic checklist is this. If this is a GI organ, then there's the mucosa, there's the submucosa, here's the muscularis, and here's some connective tissue outside the muscularis, which is either adventitia or serosa. Okay, that's this part over here. So the whole West Coast, all of California is your classical large bowel. Now, what do we really have here? What it looks like we have here is a projection of the submucosa into a polypoid structure. And if you agree that it looks polypoid and it's a projection, then you already have the name of the diagnosis. It's a polyp. But the GI doctor is not going to be happy if you just call this a polyp. You want to know why? Because if you call it a hyperplastic polyp, he's going to lose money because he's going to have to tell the patient, oh, there's no chance that these will ever turn into cancer. And therefore, he's not going to make as much money as if you call it an adenomatous polyp, in which he could tell the patient, well, these have a statistical chance of being associated with cancer, so you got to come back in 3 months or 6 months. Otherwise, if you just call this a hyperplastic polyp, he's going to have to say, come on back in 10 years, you know? So the GI doctors are your friends. You want to make some money for them. You know, they support you. And you don't want to make a diagnosis that's going to cause them to lose money. But nevertheless, let's blow this polypoid area up a little bit more. So now you have to decide whether this is an adenomatous or hyperplastic polyp. And in about 10 seconds, I think you'll all see it. Do you see the blow up, folks? I'm assuming most of you probably do. Okay, good. So do you remember when we talked about neoplasms? We said that a true neoplasm, whether it's benign or malignant, is probably a clonal, C-L-O-N-A-L, proliferation of cells. In other words, if a neoplasm is a clonal proliferation, then all the cells of the neoplasm are the same. So it means they're going to look the same. If they are the same, they're going to look the same, aren't they? Well, let me ask you this. When you look at the mucosal cells here that are thickened, do you say it looks like one type of clonal cell, or do you see a mixture of goblet cells and absorptive looking cells? In other words, is there a mixture or are they all the same? Okay, you all agree. It's a mixture. Good. So if it's a mixture of cells, it means it's probably not clonal, right? So if it's not clonal, it's probably not a true neoplasm. So let's get back to the final diagnosis now. That will enable you to sign this case out, make your, $100. Of course, after, even if you charge $100, Medicare will only give you 10. So it doesn't make a damn bit of difference what you charge. So is this a hyperplastic polyp or is this an adenomatous polyp? Jane says adenomatous. What does Carolyn say? What does Rick say? Yeah, Carolyn, you're right. This is hyperplastic. The consensus is hyperplastic. Jane is going to have to yield to the group. The reasons why it's hyperplastic is because there's a mixture of various types of epithelial cells. If it was adenomatous, it would be a true adenoma, and there would be only basically one kind of cell. But here, I'm going to blow it up even more. And I think in about 4 seconds, you could see this, the epithelial cells of this neoplasm are both goblet cells as well as the absorptive looking cells. So it's a mixture. So it's not clonal, which means it's probably not even a true neoplasm. It's probably more like a mucosal hyperplasia. And that's why it's called a hyperplastic polyp. Okay. Did everybody get that case? And can everybody see the big blow up right now as well? Okay, good. Let's move on to the next case. Let's go to case number K169. And I think we might have seen this slide before somewhere along the line. But let's look at it again. And I know what you're thinking already. As soon as you see, oh, it's 9:55. We'll take a break in 5 minutes. I'm sure as soon as you see this case, you're going to say something like, gee, it kind of looks like a gastrointestinal slice, but the mucosa doesn't look like mucosa. It looks really funny. It's really purple. I don't see the glands too well. So you can see the muscle layers pretty good. You can see the serosa pretty good. You could see the submucosa pretty good. But the mucosa looks all fuzzy and purple and like it's not even there. Correct? Can everybody see the slide? Okay, good. I'm going to blow it up now. I'm going to blow up only the mucosa because I know that that's what you're worried about. So you don't really see much of a mucosa. It looks like the glands are gone. And it looks like the glands are replaced by these little fuzzy hairs completely occupying the mucosa, wiping out the glands. They don't look like cancer cells, but they look like little fuzzy hairs. Yeah, and Samir is saying, I saw this man before, Kimosabi. Sure, I'm going to blow it up one more power, by the way. Okay, so in about 5 seconds, you're going to see a typical view of the mucosa and what the glands are being replaced by. And it looks like they're being replaced by little tiny hairs that are growing. Sometimes they look round like little yeasts, and sometimes they look like branches like little hyphae. So I would imagine about 10 seconds, everybody will see it again, and you'll probably get the right, you lost the whole damn thing. No, you didn't. You're still online as far as I could see. Okay, good. You're all back. Margaret, what's the diagnosis? Absolutely. This is the most common fungus to infect anything in the body. This is candidiasis. And whereas I told you that it's very, very common to infect squamous mucosas like esophagus and oral cavity and anywhere where there's a non-keratinized moist squamous mucosa. In this case, you have it replacing most of the mucosa of the colon. So yeah, this is probably a HIV patient. I agree. Somebody that's tremendously immunosuppressed. And you can believe that if he has this all throughout his colon, it's probably all over his esophagus as well. Thank you. Uh, let's do one more case, and then we'll take a break, okay? You don't have a choice. I don't have to ask you, okay? You don't have a choice. Let's go to case number AACR 1831F. It better be there. It's not there. So let's go to the other one then. Let's go to 081. I don't like this, but you'll soon see something interesting. Probably in about 10 seconds, you'll see the picture. Okay, Samir says, wow, so he's looking at it. Carolyn can see it. So here, let me ask you the question. Let's say I told you this was, remember, go back to your basic algorithm. Don't get fancy. Don't start playing Sherlock Holmes. Go back to your basics or you will make a big mistake. The first thing you got to do is say, what is the normal tissue? And in this case, it looks like it's some kind of GI organ again. But now the mucosa is not glandular, but it looks squamous. So what's the organ, folks? Of course you know what it is. You know it's an esophagus. I know you're all going to say it. So you have a normal esophagus here on the left. And then on the right, it looks like there's some kind of massively dark change to that normal non-keratinized squamous mucosa where it looks darker. And it also looks like it's pushing stuff into the wall. So even if we don't blow it up, I think you probably have a pretty damn good idea what the diagnosis is already. And if there's a wise ass out there that wants to say carcinoma, like Margaret, then you're right. But let's look at it in a little bit higher power too. I'm going to blow it up another notch or two. So here we are. This whole left side of the screen is a normal squamous mucosa. Oh, maybe there's a little bit of inflammation in the subepithelial connective tissues or submucosa. But look, there seems to be a relatively abrupt change here where you go from the normal maturation pattern from the basal layer to the superficial layer. And now the whole damn thing just looks darker. And it doesn't look like you're getting that normal maturation pattern. It looks like everything is dark. And in addition, you could see that not only is everything dark, but some of these cells are actually invading through the muscle. So this is an infiltrating squamous cell carcinoma, isn't it? And what else do we want to say about it? Oh, yeah. Here's what we'll say. Let's say this wasn't a squamous cell carcinoma of the esophagus, which most of them are. Let's say it was the second most common type. which is adenocarcinoma. Let's just say that theoretically. Well, if it was an adenocarcinoma of the esophagus rather than a squamous cell, would it most likely arise from the lower part of the esophagus or the upper part of the esophagus? Of course, lower is correct. And Rick, if it arose from the lower part of the esophagus, what disease, what benign disease would have probably preceded it? Right, GERD. Well, GERD is the clinical disease, but what's the pathologist disease? How about Barrett's esophagus? Because chronic GERD, you're right, can be a prelude to Barrett's esophagus, but Barrett's esophagus is the tissue word, and Barrett's esophagus almost always precedes adenocarcinoma. Okay, last question. Let's say you don't give a damn whether this is a squamous carcinoma or an adenocarcinoma. Let's say you don't give a damn. But let's say you looked very carefully at the muscle that the epithelial cells were invading. And let's say you very carefully go through this muscle and you say, well, yeah, this is a smooth muscle, but let's say you find some striated skeletal muscle in there too. So here's my question. Is this the lower part of the esophagus then, or is this the upper part? Of course, it's the upper part. Thank you. I think you're all picking up the general principles. We're going to take a break for 10 minutes. We're going to come back and do a few more GI cases, maybe a couple liver and pancreas cases. Is that okay, Margaret?
It's good.
Now, Isla, are you going to play some music for the break, or do you want me to do another slam dunk great song?
Also, I was able to pick up Mohammed, so I believe he's with us.
Okay, good. Are you with us, Mohammed? If you are, say hello. Unmute your microphone and say hello.
He's writing.
Oh, Mohammed, unmute your microphone and tell us 2 words about yourself. Where are you from?
Yeah, I'm originally from Egypt.
Egypt?
I went to.
Okay, great. Great. How long have you been in class with us? For more than 10 minutes?
Yeah, about 10 minutes. Yeah.
Okay, have you been here long enough to see that we have fun here?
Yes. Also, I enjoy your general pathology.
Good. Well, guess what? You're allowed to have fun with us too. And you can say anything you want and ask any question you want. But thank you, because when you were not speaking, you probably had your microphone muted, and that's the main rule. Otherwise, we waste bandwidth. We're going to take a 10-minute break, and then the queen of this conference, who is Margaret, Queen Margaret will tell us in 10 minutes that we have to quit having fun and do some work again. Okay, Margaret?
Okay, great.
Bye-bye.
Thank you, sir. You're doing a good job, sir. Thank you.
Thank you, Mohammed. Thank you for coming.
Hey, coffee break's over. Back on your heads.
You the man. I know Antoinette was enjoying it so much, but we do have a little bit of more pathology to discuss. Um, you know what, Mohammed, are you still there? Uh, I'm curious. Are we coming through loud and clear into Africa today? Are you hearing us well and seeing us well? Oh, great. Well, I'm very happy to report then that we're broadcasting to 4 continents today, because as you know, the Caribbean, the southern part of the Windward Islands is on the South American plate. We have a couple of people here from North America. We have at least one from Europe, and we have one from Africa. So we are quadricontinental today, and everybody's happy, so we're probably doing it right. Um, let's do some more cases today. We were kind of on a roll, and it seems like everybody was seeing and hearing pretty well. So I want to finish off on a few GI cases, and then I want to go to a couple liver and pancreas. And as long as everything is still working well, let's rock and roll. The next case I want to show is 4393. And you'll probably all see it in a few seconds, I think. And this is a really sort of an extremely easy diagnosis. For example, let's say that we went through our usual algorithm and we at first tried to identify what part of the GI tract this was. Well, the first thing you would think of when you saw this glandular type of mucosa, the first thing you would think of is, this is not esophagus. I mean, you might have a little bit of a hard time figuring out whether this was stomach or large bowel because you don't really see all the muscle too well. But the first thing you would say was, this is not esophagus. Right? Right. But what if I told you this was esophagus? You would say, well, what the hell is intestinal type mucosa on an esophagus that should be squamous? Okay, folks, what's the diagnosis? Barrett, of course, Barrett. Thanks, Jessica. you get the gold star. And it's really a slam dunk easy diagnosis because what you do is you have intestinal or let's say gastric type of epithelium replacing squamous. Now you remember when we talked about squamous, when we talked about metaplasia in general on chapter 1, we said usually the columnar cells are replaced by squamous cells in squamous metaplasia. So you could think of this as a reverse squamous metaplasia. You have GERD or reflux into the esophagus, and therefore the squamous cells are not equipped to handle stomach acid. So they make a mucus epithelium that neutralizes the acid. And that's the whole explanation for Barrett's esophagus secondary to GERD. So let me ask you this. If let's say if 90% of the carcinomas of the esophagus, it's actually not 90, it's more like 75. If like 75% of the carcinomas of the esophagus were squamous cell carcinomas. If this part of the esophagus ever became malignant, would it be a squamous or would it be an adeno? That's the question, folks. And Jessica says, adeno. Of course it'll be adeno. Why? Because it's glandular epithelium. Thank you. We don't really have anything more to say about this, except if you wanted to zoom in to see the nuclei of the columnar cells, you could. But you already know that these are columnar cells because you have enough experience for that. And so let's move on to the next case, 4437. Another slam dunk easy case. Plus, it may be something that we saw before as well. Okay, you know this is GI Day, so you know this is probably some type of GI organ. Well, let's do the algorithm. We could see a lot of muscle over here on top. I'm assuming in a few seconds you'll all see that the whole upper part of that field is muscle. And let's say you don't know what or care what kind of muscle, but you could see some submucosa underneath it, which is loose vascular connective tissue. And then you could see the mucosa as well. Now, folks, take a look over here in Florida, and I want to ask you a question. And I know it's not fair because I'm not really blown up, but we're using the principle of back up. You don't have to zoom in to quickly recognize something. Is this mucosa here squamous or is this glandular mucosa? Anybody want to make a quick guess? Jessica, you are kicking ass today. Of course it's squamous because it looks like squamous. So if I told you that this was a GI organ and you see a lot of smooth muscle and it has a squamous mucosa, then what part of the GI tract is this? Of course it's an esophagus. Now, the first thing that you're noticing is that the esophagus should have a squamous mucosa, and then it should have some little vascular tissue, looser tissue in the submucosa, and then you got muscle here. But what is the prominent, which of the 4 layers of the GI tract is the abnormality in here? Mucosa, submucosa, muscularis, or adventitia? Which of the 4 layers has the problem?
The adventitia.
Of course, it's the submucosa
Mm-hmm.
because you have all of these huge, dilated, horribly dilated vascular spaces in the submucosa. So at this point, does somebody want to guess the diagnosis or should I terrorize you into it some more? What would you call massively dilated, thin-walled blood vessels or veins in the submucosa of the esophagus to the point where it looks like it might even rupture the squamous mucosa and the patient's going to bleed to death. Of course it's varices. So let me ask you this. What major organ of this body is probably shot? Kidney, liver, brain, pancreas, gallbladder. Of course, this is varices of the esophagus going hand in hand with hepatic cirrhosis. Okay, let's do another one. This was easy. They're getting so easy now. We should probably just go home. We're so damn smart. Let's go to B33, which is over here. Okay. Jim, you don't count for being smart, but that's okay. You're smart anyway. You'll probably be able to pass the path boards by the end of this, even if you just watch us and tape the show. Okay, folks, what if I told you that this was a GI organ as well? And well, the first thing you would say is, well, I could see kind of like a glandular mucosa, and I could see a lumen over here. And then I see some irregular, smooth muscle that looks dark and light, and there's a lot of vessels. And you would probably say, gee, it can't be an esophagus. It doesn't have the lamina propria like you see in a small bowel or a large bowel. It's definitely not stomach. So yeah, let's look at those red colors, Samir. Let's look at them right now. We're going to zoom in on this damn thing. And in a few seconds, you'll be able to see a papillary kind of a mucosa, but there's a lot of red dilated blood vessels, and you can see some red dilated blood vessels here, and you can see some hemorrhage here, and you can see that the smooth muscle is disrupted by infiltrates of some kind of cell. Yeah, there's hemorrhage, but don't forget, besides being hemorrhage, there's a lot of dilatation of blood vessels. Remember, the number one cardinal sign of acute inflammation is dilatation of vessels. So let's blow it up a little bit more. What if I was to convince you that if we blew this up a little bit more, and probably in a few seconds you'll be able to see it? Well, hemorrhoids might be a good guess, but remember, this is not squamous mucosa. This is columnar mucosa. Do you see how they're in a nice orderly array over there? In fact, I bet you that nobody can even guess what organ this is. You're going to kick yourself when I tell you. This is a gallbladder. Remember how nice and beautifully the columnar mucosa stands up in a gallbladder? Yeah, Lois, you're right. It's a gallbladder. And look at, you see all of these neutrophils infiltrating the mucosa and the muscularis of the gallbladder, and there's a tremendous vascular dilatation. So what's the diagnosis? Carolyn, what do you call it when you have neutrophils infiltrating the gallbladder wall?
Neutrophils and it's colo
You're close.
inflammation of the colon
Look,
lithiasis.
you're close.
Colon,
Acute.
colon, acute. Wait.
Acute cholecystitis.
Cystitis. Okay, that's right. Acute cholecystitis. I forgot
What,
about
what,
the acute.
what would be one of the most feared consequences of acute cholecystitis? The fact that the gallbladder would rupture, you'd have all that bile in the peritoneal cavity. So yeah, that's why they take them out, for the same reason they take out an appendix. It could become gangrenous, it could rupture, you could have bleeding, you could bleed to death, and even more, you could have tremendous morbidity if that gallbladder wall would rupture, and now you're releasing bile into the free abdominal cavity. Because if you remember, the gallbladder is intraperitoneal, which means you could see it when you look in the abdominal cavity. Yeah, somebody with a busted gallbladder could very easily die in septic shock. And because I call this acute cholecystitis, if we go to where these inflammatory cells are in a higher power, we would see that they are lobulated. They are neutrophils. Oh yeah, you'll probably see some lymphocytes as well. But following the classical principles of acute and chronic, neutrophils in any organ, primarily neutrophilic infiltrates means acute inflammation of that organ. Added to the fact that the blood vessels are tremendous. Yeah, neutrophils are the big key. Okay, we're done with acute cholecystitis. Let's do another one. Let's see if we have this here or whether I got a, nope, I don't think we're going to see it on this one. So hell with that. Let's go to 4371. Oh, you're going to love this case. You're going to love this case a lot. And even if you don't, I'm going to love it. And you probably won't even have to blow this up very much. Okay, in a few seconds, you're going to all see another cross-section of a gastrointestinal organ. And I would assume you probably all see it now, right? Okay, good. Tons of fat on the top. So you know that that is either the serosa or the adventitia. That's the connective tissue. You can see some big blood vessels in that mesentery as well. In addition, you can see this big band of smooth muscle. So you know that's the muscularis. In addition, you could see submucosa and mucosa. Now, I'm not even going to have to blow this up. Yeah, there's a lot of lymphoid follicles in the serosa. There's a lot of lymphoid follicles in the muscularis. There's a lot of lymphoid follicles in the submucosa, and there's a lot of inflammatory cells in the mucosa. So this is an inflammatory disease of bowel in which all the full thickness of the bowel layers, all 4 layers, are involved. So here's the question. Is this Crohn's colitis or is this ulcerative colitis? Of course it's Crohn's. And now that you know that we said ulcerative colitis primarily is mucosal, but we said Crohn's is usually full thickness. And look at, you even have infiltration through the smooth muscle over here. Can you see this here in the southwest? Can you see this pink thick band of smooth muscle being infiltrated by inflammatory cells? This is a full thickness disease. In other words, if the normal thickness of the small bowels, let's say 2 or 3 millimeters, this one could be easily twice as thick because of all the edema and infiltration and the thickening of the mucosa, the thickening and infiltration of inflammatory cells in the submucosa, the muscularis. And last but not least, if you really wanted to prove, if there was any more doubt in your mind and you wanted to prove this was Crohn's colitis rather than ulcerative colitis, then you would blow it up like I just did over here. And you would say, look, this is a little granuloma. So we said whenever you see granulomas as part of an inflammatory infiltrate in the bowel, you know it's Crohn's colitis, because another name for Crohn's colitis is granulomatous colitis. Okay, last question, folks. Let's say I told you that bowel fistulas are characteristic of either Crohn's colitis or ulcerative colitis. What one would you guess it would be? Crohn's. And the reason is because remember, in ulcerative colitis, you do not get much inflammation in the smooth muscle, and therefore the integrity of the bowel wall stays preserved, even in severe ulcerative colitis. But in Crohn's colitis, you have infiltration of that wall and the smooth muscle with inflammation, and therefore you weaken it. So fistulas are much, much, much more common in Crohn's colitis rather than ulcerative colitis. Oh, and by the way, can you see over here? Just say yes or no. If you could see these inflammatory cells completely infiltrating the longitudinal muscle layer as well. Good, you can all see it. You can see smooth muscle here, you can see smooth muscle here, and you could see a band of inflammatory cells completely dividing that layer of longitudinal muscle. And the reason why you know this is longitudinal muscle is because it's the outer layer. The outer layer is always longitudinal in the small bowel, and actually in most of the GI system. Okay, should we move on to the next case? I'm still waiting for Antoinette to type something up. You know what? I always wonder, like when I chat with people, ooh, I think Antoinette might need to be connected again if she isn't already. In fact, I don't even see her on here. Yeah, Margaret, I think you have to connect Antoinette again.
All right,
Oh,
I'm
no.
trying.
Okay, I see her. She's there. So it looks like everybody else is okay. So let's do another case. By the way, can everybody still hear and see me pretty much? Okay. Here's another nice case. It's called 080. And I think you'll agree that it's GI again. And in a few seconds, I think everybody will see it. And I think you could see some connective tissue, loose connective tissue that's outside the smooth muscle. I think you could see a pretty good little band of pretty uniform smooth muscle here. Here's the longitudinal layer. Here's the circular layer. And then you see a bunch of normal looking glands in the submucosa. So ladies and gentlemen, what is the only part of the gastrointestinal system that has submucosal glands normally? I'll accept all answers. Duodenum, of course. So this is duodenum. You can see parts of the mucosa here in the extreme southeast. And then you see a lot of normal looking submucosal glands. Then you have your circular and longitudinal. And then you got a little connective tissue. And you know, 90% of the duodenum is retroperitoneal. So this is probably adventitia rather than serosa. But look, all of a sudden, you have an area here now in which all it looks like there is a little bit of connective tissue. You lost your mucosa, you've lost your submucosa, you've lost your muscularis. So it's the duodenum, and you have an area that's paper thin. What would you like to diagnose? Of course it's an ulcer. And because if you know, almost all these ulcers are related to acid problems, what adjective would you like to put in front of that ulcer? Peptic ulcer. I think that's what I'll be seeing in a few seconds, I hope. Yeah, of course. So let me ask you this. Do you think that this is a long-standing, severe, dangerous ulcer? Or do you think it's just a mild little thing, you know, because of a little bit of aspirin or something? Or do you think possibly this guy could possibly die pretty soon if this tiny microscopic fibrous layer here ever ruptured. He's spilling gastric contents into his abdominal cavity then. Yeah, this is a very dangerous ulcer. This is something that is paper thin. It's almost completely eroded through all four layers. This is a severe ulcer. Now, let me ask you this. If you looked at the base of the ulcer and there were a lot of neutrophils, would you call it an acute or a chronic ulcer? Let's say you looked at the base of the ulcer and there was a lot of fibroblasts and some lymphocytes. What would you call it then, acute or chronic? You're right, I'd call it chronic too. But the fact is, whether you call it acute or chronic doesn't matter very much. This is a very, very deep, penetrating ulcer. What word would you use in place of penetrating if this tiny little membrane is breached? You would no longer call it penetrating. You would call it perforating. Thank you very much, Carolyn. Take a bow. Okay, let's do another case. Oh, you know what? Let's do two more GI cases, then we'll do liver. Let's do K193. K193 is right over here. Okay. Folks, let's say you agree easily that this is some part of the GI system. And you could see that there is some kind of mucosa. You can see a bunch of muscle up here. You can see a lot of nice loose vascular submucosa. And you could see that the mucosal pattern does not look papillary or villous like a small bowel. So that means you know that this is either stomach or large bowel. And even an experienced pathologist could very easily on a bad day call this a large bowel. But if you look a little bit closer, and we will, you're going to see a lot of those very, very sunny side up egg looking cells. So you know this is stomach because all of those nice bright orange cells are parietal cells, aren't they? And the darker ones are chief cells. So look, you see where my little pointer is? These are chief cells over here. But most of these little cells with the central nucleus and tremendously orange cytoplasm, these are parietal cells. Oh, I would imagine your picture will be coming back very soon, I hope.
See it now.
Okay, good. So this is a stomach. That's all we wanted to do is we wanted to demonstrate the fact that you're seeing parietal cells here so you know it's stomach and it's not colon. Because remember, the mucosal pattern of the colon is a lot like stomach in that it's not a papillary structure. It's basically a flat thing where you got the pits and you got the crypts. Okay, well, now that we decided that, let's blow up another area, which I'm going to do very, very soon. In about 8 seconds, everybody's going to see this blown up area. And I want to remind you, by the way, this is not a trick or a difficult diagnosis. This is a diagnosis that you should have been able to make on day one of this pathology course because you know what stomach looks like histologically, and you know that when you see these lymphocytic or chronic inflammatory cells disrupting the muscularis mucosa, disrupting the lamina propria, and forming these little nodules. Well, you know what? I think that the word ulcer would probably be appropriate if you could document the fact that a lot of this mucosa or epithelium is eroded or lost. This could very easily be a superficial ulcer. But Carolyn, I want you to get even more basic than that. What do you call a gastric mucosa that's infiltrated by lymphocytes? It's not an appendix, it's a stomach. It's an incredibly easy diagnosis. It's gastritis. Of course it is. Carolyn, you called it acute ulcer. That means you think you're seeing neutrophils. But you could see from here, even without blowing them up, these are lymphocytes. These are lymphocytes. These are lymphocytes. So this is chronic gastritis. That's the only thing I wanted to point out. And let me ask you another question. No, you were pretty close, Carolyn. That's okay. Let me ask you another question. If this inflammatory infiltrate was pretty extensive and it caused mucosal atrophy and it interfered with the parts of the stomach that makes intrinsic factor, what kind of anemia would you expect this person to have? Iron deficiency or megaloblastic? Margaret says iron. No, Carolyn says iron. Antoinette says iron. Jessica says iron. You're all wrong. Oh, you know what? I'm sorry. If the person was hemorrhaging chronically because of this, because of ulceration, yeah, they would be iron deficient. But once again, here's my question. Let's say that this inflammatory infiltrate impaired the cells that made intrinsic factor. What kind of anemia would you get when you have problems with B12? Thank you, thank you, thank you. I think you all got the question. And right, and if they were losing blood, they'd probably be iron deficient as well. Okay, last stomach case, and then we're going to go to liver. In fact, we may just do a couple liver cases here. But I want to do one more stomach case. That's going to be kind of interesting. It's called case 68. And here it is. And I should probably get rid of this old one here. And probably in about 8 seconds, everybody's going to see this slide. And guess what, folks? I'll spare you half of the guesswork here. I think I could convince you pretty easily this is a stomach. I think you could see a mucosa on the top. I think you could see a pretty nice sort of hemorrhagic vascular submucosa. I think you could see a nice little thick line of muscle. And then I think you could see a serosa here. So the easy part is this is a stomach. The funny part is, what are all these nodules in the stomach? Look, here's a nodule, here's a nodule, here's a nodule, here's a nodule, here's a nodule. There's a lot of them in the serosa, and there's even nodules here in the submucosa as well. So does anybody want to zoom in and study these nodules a little bit more detail? Yeah, let's look at a couple of these nodules. Let's look at one. Let's look at this nodule here. Okay, we're looking at one of the nodules. And in a few seconds, you're going to see a nice, relatively smaller nodule that has been zoomed in on. Okay, good. So here's the nodule. You could see that in the middle of these nodules, there's no cellular detail at all. It's like it's necrotic. And in parts of these nodules, you could see cells that look like they have multiple nuclei within them, like over here, and like over here, and like over here. So does anybody remember what this nodular structure would be called if it has a lot of histiocytes, giant cells, and a necrotic center. What type of inflammation is that? I'm waiting for some answers. Come on. These are granulomas. This is your classical day one uh, granuloma 101. So if the granuloma had a necrotic center, would you call that a caseating or a non-caseating granuloma? Okay, remember, it's necrotic in the center. So is caseation a type of necrosis? Well, Jessica says none, but I'm looking for another opinion. Yeah, well, it's necrotic in the center, and with granulomas, you know, the word caseation is also used. So here's the last and final question. I want you to fill in the blanks, folks. Caseating granulomas are blank until proven otherwise. Fill in the blank. No, I'm not throwing you off. This is something I've said 100 times. If you see a caseating granuloma, what's the most likely diagnosis? TB, TB, TB. Yeah, of course it's TB. So if you saw a caseating granuloma, what stain would you order to prove that it's tuberculosis? Yeah, this is TB of the stomach. I know you don't normally think of a stomach as getting tuberculosis, but let me tell you something. You could get tuberculosis of any part of your body, not just lung. There's only there's only two places of the body that I've never seen tuberculosis in. One is skeletal muscle and the other one is thyroid. I think I've seen TB in just about every other part of the body you could imagine. Yeah, and that's why they call it consumption. It destroys everything. So what do you take home from this slide? What you take home from this slide is caseating granulomas are tuberculosis until proven otherwise. So if you did a fungal stain and you wound up having blastomycosis there, then you know it's not TB. But if you did an acid fast or a Zeal-Nielsen stain and you saw those tiny little red bugs, then you just confirmed what your suspicions were, that it's tuberculosis. And statistically speaking, most caseating granulomas are tuberculosis. Yes, Zeal-Nielsen. I think it's spelled Z-I-E-L, and I'm not sure, but you pronounced it right at least. Last case we are done with. Let's go to a couple liver cases now. The most important liver case, the most important liver slide I want to show you is slide number I hope it's here. I hope it's here. Yeah, this is the most important liver slide I want to show you right here. In fact, I'm going to blow it up right away. So when you see it, it's already going to be blown up relatively nicely. Okay. Yeah, I know you're looking at the old one. In about 5 seconds, you'll see a nice piece of liver here. We might not get the chance to go through all the liver slides, but remember, we showed pictures of them, and we started to do a few of them, and we had a whole lab where we did liver when we were on the island. So I'm guessing that by now, almost everybody here is looking at liver, right? Oh, I see a nope, nope, nope. Well, hold on. Let me get rid of that old crappy thing then. Let's do liver. Histology. I don't like this. Okay, in about 5 seconds, everybody's going to see liver. First person to see liver, let me know. Oh, don't tell me you don't see liver yet, because I know that our dim is still on. Nobody sees liver? Okay, well, we got a problem again, folks. You don't see liver. Come on. Our dim is still on. Oh my God, you still see the TB slide. For some reason, we're not broadcasting liver.
Maybe the screen is frozen. That happens sometimes with dim.
Okay, well, according to my dim page, dim is still working good, and we're still broadcasting, and we still have enough time. We didn't run out of time. So, okay, folks, if you can't see liver, and we only got a few minutes left for today, then I'm going to have to tell you to do something. This is going to be critically the most important thing. Okay, I'll say share screen again. Okay, we'll say share screen again. But I think we're already sharing it. Settings, well, guess what? We're saying share screen, but it's not sharing. Okay, I think you'll see it in about 10 seconds, folks. I think you'll be seeing liver in about 10 seconds. I'm about to see a whole big slew of people saying that they see liver. Okay, it's black, but it's coming. Okay, I could tell you're all seeing liver now. No, no. Samir sees liver. Dolores sees liver. So in 10 seconds, everybody will see liver. Okay, we all see liver. Okay, good. Look at this liver. This is our last case for today. Look at the liver. I want you to write something down. This is so important. I'm going to tell you what the algorithm is for liver. You ready? Yeah, it's nice and pink. In fact, it's probably too pink. But do you see this central vein here? You can see that there's some little bit of congestion in it, but there's no connective tissue around it. So you know it has to be a central vein. On the other hand, what you see here and especially here does have a bile duct and connective tissue and maybe a little bit of artery. So you know this is the central vein and this is the portal vein. And here's another portal vein. And it looks like this could possibly be a central vein. It is because there's no connective tissue. And here's another portal vein. Okay, are you seeing all that, folks? Because what I'm about to tell you is extremely important. When you look at a liver, make sure that you generally have a good general regular interrelationship between central veins and portal veins. Write that down. Write that down. That's the first thing that you notice. And also notice, number two, is that when you look at portal veins like you see here in the extreme southwest. When you look at portal veins, make sure that the connective tissue is limited only to the portal vein area. Because if it bridges to an adjacent portal vein area, then that's probably early cirrhosis. So all of your loose connective tissue has to be limited to the portal triad. And of course, around the central vein, there is no connective tissue. And you generally have to see that the central veins are kind of regularly interspersed with the portal veins. Now, if you remember, I said about 10 times, I called it a hexagonal architecture, and that's what the pathologists use. They use the word hexagonal. All that means is regular. In reality, you'll never really see true hexagons like you see in the textbooks. But just remember, you have to have sort of a regular interval between the central veins and the portal veins. And as you remember, the direction of flow is from the portal vein in the hepatic artery down the sinusoids to the central vein, then from the central vein to the hepatic veins, from the hepatic veins to the IVC, from the IVC into the right atrium, and you know the rest of the story. It's so important that you use that as your algorithm for every case. Because in hepatitis, you'll see inflammatory cells in that portal area. And maybe they'll even extend into the sinusoids and central vein areas as well. In cirrhosis, you'll see that that connective tissue connects with adjacent portal areas, and that's what's forming the nodules. And that's all that I have to say. You already know how to recognize fat. You already know how to recognize bile. You already know how to recognize hemosiderin. So whenever you look at a liver, and you know, they might throw in a picture of some liver disease, hopefully it'll be a common one. Just remember, make sure there's a regular interrelationship between the central veins and the portal veins, and the connective tissue is limited to the portal vein area. Those are the two things. And we're done for today, by the way, because it's 11 o'clock. Did everybody hear me very well on that last case? Because that was the last case.
Yes. Could I
Yes.
make a
Okay,
request,
good.
Dr. Menard?
I
Could I
can
make a
hear you.
request?
Make a request.
Yes, I would request that all the students in the PATH group would send me their or whatever they have of their cases, and I will send you mine.
Okay, good.
My email is available, and if anyone needs it, I will be glad to forward it to them. If they
Carolyn
can send
wants
it
to,
via the
good.
Skype.
Carolyn wants to start to do some information sharing. She says, tell her what cases you're doing, and she'll tell you what cases she's doing. And remember, you're all going to be swapping that information before you submit it, because at the very end of the course, everybody submits everything, and everybody is checking everybody else's work. Okay,
Yes,
good.
if I can get the cases, yes, I will
That
send
is
mine.
a very reasonable request, Carolyn. Okay,
Thank you.
any other questions or requests? Jessica, I want to let you know you got all the right answers today. You should have a good day. Jessica's talking consolidation. Jim wants me to play some more funky white boy music. Samir said she did well.